March is Colon Cancer Awareness Month, so this is the reason for this talk. So we'll start with definition. So what is colorectal cancer? Colorectal cancer, so that will be CRC on my slides from now on, is a form of cancer when abnormal cells grow in the lining of the large intestine, which is also called colon, or the rectum. It can involve both women and men, and it has the second highest rate of cancer deaths in the United States and in the world. Before we move on to the colon cancer, a little bit of anatomy for you. So the portions of the colon are the following. So the beginning of the colon, it's called cecum. So this is the cecum, okay? So this is where the small bowel connects with the colon, the beginning of the colon. This is the appendix. Then ascending colon is the next portion that moves up. Transverse colon is called transverse because it goes across. Then we have descending colon because the stool moves down. Then we have sigmoid colon, which has usually a shape of an S. And then the bottom 20 centimeters of the colon is called rectum. And at the end we have anus. So if you draw a line from this angle called splenic flexure, because the spleen is around it, to the cecum, then we have the colon divided in two parts, right side colon and left side colon. So frequently I would refer to proximal polyps, meaning in the right colon, and then distal polyps, meaning in the left side of the colon. So how many cases of colon cancer we have in the United States? So this is a chart that shows number of cases per 100,000 persons. So that is called incidence. We have data from 1975 to 2017 approximately. So as you could see, per 100,000 people, we started with 60 cases, and then the incidence went up to 1985 or so, and then slowly started to go down. We started doing colonoscopies for screening in approximately 2000. So as you could see, the rate really went down since, from approximately 60 to approximately 40. And so did the deaths from colon cancer. Went up a little bit and then went down. So we are approximately to 20 or so. So last year, 2017, this is an estimated number of cases. We had 135,000 people diagnosed with colon cancer, and 50,000 of patients with colon cancer, which could have been diagnosed before, have died from it. In Maine, this is data from 2014, we had 45 males diagnosed per 100,000 population and 36 females. So on average, it's approximately 42 cases per 100,000 people. So if you multiply by 1.3 million people that live in Maine, we get approximately 500, 650 or so cases per year. I just had a patient yesterday with colon cancer. So we see this at least a couple of times a month, at least at Mid-Coast. So if you look at the age group, the median age of diagnosis is 67. We advise to get started for screening at 50. And why is that number 50? Because 90% of patients who have colon cancer are diagnosed after the age of 50. We can see sometimes patients younger than 50, but that's very unusual. Usually 10% or so of patients. So that is why 50 years of age, you should get started with screening, whatever form that is, colonoscopy or stool test or whatever. So if you look at the other forms of cancer by numbers, so colon cancer is number 4. So we have breast cancer in women, and then we have lung cancer, we have prostate, that's in males, and then colorectal cancer, which adds women and men. If you look at the deaths rates from cancer, number 1 is lung, and number 2 is colon cancer. So this form of cancer is not the most common one, but it's the second by, if you look at the death rate. 8% of all cancers in the United States are colon cancers. A little bit of stages. So stage 0 is when the cancer is found in the innermost lining of the colon or rectum. It's a very tiny lesion, as you could see, which could be removed with a colonoscopy. And in this case, the cancer is gone. You're cured. Stage 1, that is when the disease has grown into a muscular layer of the colon or rectum. It does not reach the outside layer of the colon. If cancer has grown into or through the outside layer of the colon, that is stage 2. If you have lymph nodes involved, that's usually stage 3. And if you have cells of cancer that have spread to other organs, usually liver, sometimes lungs or bones, that is stage 4. So it is really important that we find the colon cancer when it's early, stage 0, 1, or 2. How is the survival by stage of colorectal cancer? So out of all the diseases of colon cancer, 39% are usually localized. So that's a primary site, and that gives you a good outcome. 35% or a third of all the cases will be regional, so that's spread to local lymph nodes. Approximately 21% or a fifth will be a metastatic disease. And then 4% sometimes we don't know what the stage is. That's very rare. If you look at a 5-year survival based on stage, you have a 90% chance surviving 5 years if you have a localized disease. And that is why screening is really important. Regional disease gives you 71% chance. Metastatic colon cancer, it is bad, 14% survival. And then sometimes when the colon cancer is unstaged, the rate somewhat is better, but there is a lot of unknowns in this type of situation. 65% of patients who have had colon cancer will die from the disease at 5 years. So even maybe the stage is 2, with some involvement of lymph nodes, eventually you will find cells that have progressed to other organs, and eventually the patient will be either dying from the cancer itself or from complications caused by treatments given for cancer. So median age of death of colorectal cancer is 73. So as you could see, 25% of patients who have had diagnosis of colon cancer are between the age of 75 and 84. And the remaining population is 22.5% of 65 and so on. So this is the group that really gets hit hard. We can divide colon cancer cases in 2 big groups. Sporadic colorectal cancer and hereditary colorectal cancer. So sporadic cancers is 95% of all. So that is when someone gets cancer and we don't know why. It just happens. It doesn't mean that you had relatives with colon cancer. So this is usually a case when healthy cells in the colon develop errors in the DNA. These cells start to multiply and grow and divide without any control. Eventually they accumulate and form tumors, and that is colon cancer. Hereditary colon cancer is only 5%, and that usually involves younger populations. So that's when we have patients with cancer being diagnosed at the age of 40, 30, or even younger than that. So that's caused by inherited genes that have mutations which increase the risk of colon cancer and are passed from family to family. These patients do not mean that they will get 100% cancer, but most of them will get for sure. So there's 2 groups of hereditary colon cancer that you need to know of. One is called Lynch syndrome, or HNPCC, hereditary non-polyposis colorectal cancer. These patients do not develop typical polyps. It's usually flat, small-sized polyps that become malignant really fast. So these patients have high risk of colon cancer and also other organs, breast cancer in women, uterine cancer, ovarian cancer, gastric cancer, small bowel cancer, pancreatic cancer. So it involves a lot of organs. If we know about a family member who has a possibility of having Lynch syndrome, then we do genetic testing. And then we test family members. So that way we define who is at risk and who is not. FAP, also known as familial adenomatosis polyposis, that is a case when patients develop thousands of polyps. The whole colon has polyps everywhere. And these patients will get cancer for sure before age of 40. And most of the time, we would advise them to have their colon removed because it's impossible to to chase and find all these polyps and get them out. So what are the risk factors for colon cancer? There's some risks we can control, and there's some risks that we cannot. We cannot change the aging, right? So that's why when we get 50 years of age, we gotta get our screening done. Patients who have inflammatory bowel disease like Crohn's or ulcerative colitis have higher risk of colon cancer. That's why we advise them to get screening done every couple of years. Family history of colorectal cancer. It doesn't have to be hereditary forms that I mentioned earlier. You may have some gene that we don't know of, and you have a higher risk. That's why we want these patients to get screened a little bit earlier. And also race. We know that African Americans have a higher rate of colon cancer. That's why we're starting screening at age of 45. Now, you can control some things, though. We can quit smoking. We can cut on alcohol intake. We can get more active, so that way we have a lesser chance of getting overweight or being obese, and we can eat healthy. So eating less red meat, less fat, less processed meats, more fiber, and also not meats that are not cooked at high temperatures. These are only a few of the things you can do to be healthier. So why we talk about polyps? Many years ago, there was a scientist down in Baltimore, Hopkins University, that found that all the colorectal cancers will evolve from a structure called polyp or adenoma. So what happens with a polyp is you have few cells, as I mentioned earlier, that hyperproliferate. So they start multiplying, and you have a little bumpy 1 or 2 millimeter structure on your mucosa of the colon. This eventually gets on the big in size, and then even bigger than that, and eventually becomes a typical polyp structure. So the bigger the polyp gets, the higher chance of this to be precancerous and then cancerous. So doing a colonoscopy when you have small polyps, it's easier, it's more helpful because we can find the structures before they become malignant and remove them without patient undergoing surgery. While when the cancer is already in the polyp and has spread through the layers, it is already too late to take care of it with an endoscopic procedure. So this process is called adenoma to colorectal cancer sequence. And that's the base of our ability to prevent cancer by performing screening. So we know that 20% of women will have adenomas, and we know that 30% of men will have adenomas. Those are numbers that are clearly defined by GI literature. And that is in patients who are older than 50. Not all polyps are created equal. So I'm going to mention 3 of them. So the first polyp that I want to touch on is called hyperplastic polyp. And these are polyps that are usually located on the left side, rectum and sigmoid colons. These polyps are usually very small in size. They're flat and whitish in color. And we know that approximately 20 to 40% of patients will have these polyps. These polyps are not precancerous. They're very benign. They will not get into cancer. Sometimes when we see polyps like this, they're very small. We don't even have to remove them. We will remove this type of polyps when we don't know if they're hyperplastic or not. But by looking at the polyp during the colonoscopy, you can see with almost certainty that this polyp is really hyperplastic and it doesn't really bring you any harm. Adenomas, for example, this polyp noted on the left, has this semi-pedunculated structure. It's a little bumpier on the mucosa and has this kind of a structure of little worms on its surface, has a pitting appearance. 65% of all the polyps in the colon are going to be tubular adenomas. And this is the types of polyps that I like to find and remove because they're very small, easy to take care of, and it's done. However, if you don't get the colonoscopy on time done, then this little polyp will become things like this. Bigger in size, maybe an inch, maybe half an inch size. And this polyp is called tubulovillous adenoma. So there's 10% of polyps. They will always be big in size. We can even remove this one without any problems. And they're usually benign. Sometimes we would have pathologists say low-grade dysplasia, high-grade dysplasias, that's when the polyp already is starting to kind of take off into developing more of a precancerous findings. This is the polyps that we like to find and remove. So hyperplastic polyp that I showed you earlier, it's usually found on the left side. These polyps are found on the right side of the colon. 20 years ago, when doctors would find polyps like this, we wouldn't remove them because we thought, well, it's hyperplastic, so it doesn't bring you any harm, and that's okay if you don't have to remove it. But now we know that this is actually adenomas, so precancerous polyps, and they have to be removed. The problem with these polyps is they're kind of difficult to see. I don't know if you could see them on the picture, but this is kind of a very flat structure, and you could see sometimes it helps us to find them because they stain in yellow more than the mucosa. And this is the border of the polyp. As you could see, it's kind of difficult to really see the margins. Sometimes we flip the colors in the scope with something called narrowband imaging, and that kind of gives me a little bit of idea where the border is. And these polyps, again, difficult to find, but when we find them, we like to remove them because they could become cancer. 8 to 9% of patients will have this type of polyps, and we know that these are exactly the polyps we will miss during the colonoscopy. We can't see them the most. Okay. If a patient has 2 or 3 of this found during a colonoscopy, we usually bring them back in 2 years for another screening because I know I could have missed some of them. So what are the symptoms of colorectal cancer? This cancer doesn't have early signs, so it's important to come to get checked on time because when you come and tell me that you have bleeding and pain and weight loss, it may be late. So finding it early means it's more curable disease. If that disease gets worse, you can see blood and stool, have abdominal pain, have constipation or diarrhea, unexplained weight loss, you can be anemic without seeing any blood in your stool, or you could have fatigue. So by the time the symptoms appear, tumors tend to be bigger and more difficult to treat. So what is the goal of screening? Why are we doing this? So the goal is to find precancerous polyps so they can be removed before polyps turn into cancer. We're hoping to decrease morbidity so patients don't get sick from it, decrease mortality, decrease the social burden of these patients, so take them from the families and miss work, and also costs. For example, the cost of a colonoscopy, and that is cost that the insurance is being charged for, is $1,000 to $3,000. Yet the price to treat a patient with colon cancer is almost $30,000 on average. So this is the ACG, American College of Gastroenterology from 2017 task force. So what are we doing for screening? This is not a complete slide, but this is basically what we do the most. So you could do a colonoscopy every 10 years, starting at the age of 50, and if you have a normal colon, you're coming back in 10 years. Or you can choose to have annual fecal immunochemical tests. So that we're looking at traces of blood in your stool. However, if your stool test is positive, then we will advise you have a colonoscopy because we need to find out why, find the polyp and remove it. If the test is negative, that's good news. You can have another one the next year, and you can do this every year. Another way to screen is to do something called a visual colonoscopy or CT colonography every 5 years. You have to prep for this just like for the colonoscopy. And this is a CT scan. Radiologist looks at the scan and to make sure they find C polyps. The problem with this is that you can miss polyps at a very small size. It is a good study for polyps that are bigger than 10 millimeters in size. You can have fecal test for DNA. So polyps secrete DNA into your stool, which could be detected with a test. And you can have this every 3 years. And again, if it's positive, you have to have a colonoscopy to prove that you have polyps and remove them. If it's negative, then you can have another one in 3 years after that. Your insurance will pay for colonoscopy, fecal test, fecal DNA test. CT colonography is a little more difficult. We usually do CT on the patients who we've tried to do colonoscopy and it didn't work out due to a variety of reasons. Flexible endoscopy is a short colonoscopy. The problem with the Flex 6 is that we could only find cancers on the left side. We're not going to be seeing cancers on the right side because we don't get them. Capsule colonoscopy is another way, recently approved by FDA. It is very difficult to get the insurance to approve this, but if you had a colonoscopy was not successful, then we can ask insurance to maybe pay for a capsule. You have to prep for the capsule colonoscopy just like for the colonoscopy itself. Septin is not available yet, so that's a blood test. So we could divide all the tests in two groups, invasive and non-invasive. So non-invasive tests will be fecal occult blood test, stool DNA, CT colonography or virtual colonoscopy, and capsule endoscopy. So fecal occult blood test is can show if you have blood in the stool, which could be sign of a polyp or cancer. You usually give 2 or 3 samples to the lab, and then we would recommend to have this every year. And again, if it's positive, you need a colonoscopy. The cost is very small, up to $40 per test. You can pick only 80% of polyps or cancer, so 20% will be missed. And it has a specificity of 96, so it's not always positive test. That means you have a polyp. You could be positive from an ulcer, for example, in the stomach. DNA test is more expensive because it looks at different molecules, not necessarily blood, but DNA. So this could be done every 3 years. The cost is $800, up to $800 per test. And it has a good sensitivity, so you can pick 92% of the cases, and a specificity almost 90%. That's a pretty good study. The most common one that you see is called Cologuard. Actually, it's the only one FDA approved. Very frequently, I get patients who had Cologuard that was positive. They come in for colonoscopy, and we look, and we do find a polyp or 2 or more. Even today, I had a case, Cologuard positive, 9 polyps. CT colonography. So that's a CT scan of the colon. You have to prep for this, just like for colonoscopy. Cost is $439 per test. But we will miss polyps that are smaller than centimeter. And 8 millimeter, 9 millimeter polyps, that's a good size polyp. So that's a choice you have to make. And again, if you have a polyp found on the CT colonography, then you have to have a colonoscopy again, a prep again, to get the polyps found and removed. This is the capsule endoscopy or capsule colonoscopy. It is FDA approved, but it's very difficult to get insurance pay for this. And again, only can find 88% of the polyps that are bigger than 5 millimeters. So we're not going to find them all. Now, invasive screening. So that is colonoscopy. So colonoscopy is a procedure where we would insert a flexible fiber optic instrument through the anus in order to examine the colon and remove precancerous polyps if found. So this is a typical one of our rooms where we do colonoscopies. So we have the scope with a computer here where we take pictures, we insufflate carbon dioxide in the colon to make sure we're seeing which way to go. We have ability to flush water and then suction back so that we wash well. And then we have a cardiac monitor where we keep an eye on your blood pressure, heart rate, how your breathing is. And we have a nurse that's sitting on this at this desk and gives you sedation, and the doctor and the technical nurse is on this side. So we insert the flexible scope through the rectum, and we slowly advance all the way to the cecum. So when I get to the cecum, I tell the nurse I get the cecum, so she times me. So that way, when I get back to the end, it takes me no less than 6 minutes to examine the colon. That's a number that we use for quality. So make sure the withdrawal time, that's the time it gets to examine the colon, is no less than 6 minutes. And that is usually patients who have normal procedures, like no polyps. If I find a polyp or 2 or more, then obviously the time is not critical because it's going to take me more time than 6 minutes. But if you have a normal colonoscopy, you want to make sure that we have 6 minutes on board. So very frequently I would come up, so we know that the right side of the colon is where the polyps have a tendency to be missed, so I will come back and then I go back one more time, again wash again and come back and so on. So we always go back and forth. As you could see, the colon has three angles. So we have the sigmoid colon, we have the splenic flexure, and we have hepatic flexure. So this is an area where it tends to be a little more of a discomfort for the patient. So I usually, for one of the patients, if they're awake, say, you're gonna feel a little pressure right now. So the way the patient is ready, and we have some special maneuvers we do, we pass this with ease, and we move up, and then we take another turn here, and another one here. So during this procedure, again, we have a light at the end of the scope. We have a channel that we pass instruments through to remove the polyps, to take a biopsy, and so on. Or if the patient has bleeding, then we treat the bleeding. So, conscious sedation versus MAC. So, obviously, pain during the procedure is a big deal. A lot of patients don't come because they have a lot of pain. So, there's two ways we can provide you with comfort for this procedure. One is conscious sedation. So, you're giving sedation, and if you fall asleep and you dream, that's pretty good. I want to make sure you're breathing, so that's my biggest concern, you're breathing. And if I want to wake you up, you better wake up, because if you don't, that means you're not breathing that well. Now, some patients have no pain with conscious sedation at all, and they're awake. They have a little bit of a little pain medicine, there is no discomfort, they like to watch. I like that because I think the patients learn from this. However, sometimes patients want to be completely out, and they will come and say, I don't want to see this, I don't want to hear you, I don't want to see anybody. So then I say, maybe we should give you MAC, because this anesthesiologist gives you a medication called propofol, and you're completely out. That's called deep sedation. Legally, I'm not allowed to do that because I'm not an anesthesiologist. I can only do conscious sedation or light sedation. I cannot do deep. So, if I know ahead of time that the patient has a lot of anxiety, I know it's not going to work with fentanyl Versed, then we have your anesthesiologist take care of you, and I do the procedure. So, when I have a younger patient, I might give some IV Benadryl. That really helps with some anxiety and so on. So fentanyl Versed, the most common use. Fentanyl is a pain medicine. Versed is like Valium. It's a sedative. And I give both medicines. So I give the water to the nurse, she gives it to you, and I'm responsible for your vital signs, blood pressure, and so on. Now, we usually divide patients in the risk for anesthesia. So ASA stands for American Society of Anesthesiology. So they have a classification 1 to 4. So if you have class 1, that's a 50-year-old patient comes in, has no medical history, doesn't take any medications, doesn't have sleep apnea, class 1. So we can do this. Sometimes patients have, let's say, hypertension, which is well controlled, or heart disease that's well controlled as well. Then not a lot of systemic diseases, don't have sleep apnea. Then fentanyl Versed will just do the trick just right. However, if you have ASA class 3 and 4, that's usually severe systemic disease, obese patients, sleep apnea, a lot of anxiety. Or I know somebody had a colonoscopy a year ago, for example, and they couldn't finish it because the patient was having a lot of pain. So then I would strongly say, you know what, we should do MAC. I think you just need deeper sedation, it relaxes the patient. Okay, so let's talk about a little bit of a diet, right? So you can take some steps to lower your odds of getting polyps and colon cancer. So eat a nutritious diet, get enough exercise, control your body fat. So these habits can actually reduce the risk by 45%. There's some data on that. So American Society of Cancer Society recommends a diet of fruits and vegetables, light on processed or red meat, whole grains instead of refined grains. Exercise is also very important. Most active people were 24% less likely to have disease, colon cancer disease, than less active patients. It doesn't matter what type of exercise you do. So the ACS recommends 150 minutes per week of moderate exercise, like walking, or 75 minutes per week of vigorous exercise, like jogging. So you may want to try to spend the exercise every day a little bit rather than 1 or 2 sessions a week. So a few basic facts that we covered. One is 1 in 20 Americans will get colon cancer in their lifetime. 60% of all colon cancers deaths could be prevented with regular screening. Colon cancer is the second leading cause of cancer death among men and women. And 1 in 3 adults are not up to date with their screening. So 65% of patients don't only get their screening, right? So what can you do to help? You gotta share your experience or lack of experience. So if you have some time tonight, you can go to the website of Boothbay Register. I had a patient that I did a colonoscopy on in January. She was a reporter for this paper, and she kindly asked to write about her experience. So it has 2 parts. So if you put Boothbay Register and colonoscopy in Google, you'll come up with both articles. So colonoscopy part 1 and part 2. This lady has had a lot of colonoscopies because of her medical condition, and she can tell you experience from 1975 or earlier, and then she can tell you the experience from 2018 of a colonoscopy. It's a big progress. Technology, prep quality, scope quality, quality of polyps finding, and so on.